So, I mean, BTK inhibitors have become one of the standards of care for patients with Waldenström, so specifically covalent BTK inhibitors. Ibrutinib was the first one, then Acalabrutinib, more recently Zanubrutinib, that has shown to be less toxic and maybe more efficacious than Ibrutinib in a randomized study. So my sense is pretty much every patient with Waldenström's will be exposed to a BTK inhibitor at some point. BTK inhibitors are highly effective. But those are therapies that are oral and they need to be taken indefinitely. So patients really don't have a finite duration therapy with these agents. So as patients get exposed to these agents, they tend to develop more side effects. So one of the ways in which we can optimize BTK inhibitor management is actually with dose reductions. So Ibrutinib and Acalabrutinib and Zanubrutinib, you can actually modify the dose depending on what type of risks or side effects they have. This was research that we published last year from my colleague, Dr. Shana Saroshek. She actually collected our data from 400 patients, approximately 400 patients with Waldenström's who were treated with Ibrutinib, the first in-class BTK inhibitor, and we found that about a quarter of these patients needed a dose reduction because of side effects. And these side effects were multiple, from musculoskeletal pains, from rash, gastrointestinal symptoms, bleeding, and arrhythmias. We found that patients who were older than 65 and women were more likely to have side effects and they're more likely to need a dose reduction. But after the dose reduction on Ibrutinib, about 3/4 of the patients had actually an improvement on their symptoms. And if you had musculoskeletal or skin rash or GI symptoms, they were more likely to improve with dose reduction compared to bleeding or compared to arrhythmias that didn't improve that much. And the other good part about the fact that the treatment is more tolerated is you keep the patient on active therapy, and that actually allows the patient to maintain the response. So actually 80 to 90% of the patients maintain the response for 3 to 4 years after the dose was reduced. So it allows patients to get into a treatment, benefit from the treatment for longer than otherwise would happen. Now, the use of genomics is something that in our practice we're using a lot. So we are the ones that we identify the MYD88 mutations that we can see in over 90% of patients with Waldenström's. There are mutations in CXCR4 that we can see in about a third of the patients with Waldenström's. Patients on BTK inhibitors, who have CXCR4 mutations tend to have, shorter responses, for example. But we also are finding mutations in another gene called TP53. About 10% of patients with Waldenström have these mutations. And that is a mutation that actually informs about chemotherapy resistance, right? So in our practice, what I do is I profile the patients, MYD88, CXCR4, and TP53, and depending on which mutation the patient has, or combination of mutations, then we can sometimes guide the patients towards either a BTK inhibitor therapy or a chemotherapy therapy that we can, in that way, kind of assess what the efficacy of these treatments will be just with the use of genomics. Obviously, more research is necessary to understand really if this is the way to go, but this is something that we are doing in our practice very often.